Hi, everyone. Welcome to Ask the Egg Whisperer. So excited to be here again tonight. I love hearing from you guys. You guys inspire me. I learned so much from the questions you guys answer because it helps me realize that we're not alone out here, you guys. And there's so much yet for me to do. And so I know you guys know that I like to exude strength and positivity and resilience, but I have to remind my patients every single day that they are so strong and so resilient. And that's what I'm going to do for you guys. And I'm going to remind you guys that the reason why you're here, the reason why you're listening, the reason why you're watching is because of your bravery and courage. So one of my friends, Dr. Caroline Alexander, on her Twitter, someone asked, "What's your mantra?" And she said, "Inhale courage and exhale fear." And I find that really powerful because patients email me, "Amy, I'm really worried. I'm coming in tomorrow for my OB ultrasound. I'm scared out of my mind." And I just literally replied, I said, "This is something for you to remember." So I want to share that with you guys tonight as well as we start Ask the Egg Whisperer. And I'm super excited to answer your questions. And let's get started. So the first question comes from Nikki, and Nikki says, "Are there any supplements or treatments you can recommend for helping day 3 embryos reach the blastocyst stage?" So Nikki, that's a really good question. What you're asking is, what can I do to improve eggs and sperm quality? So I have a mnemonic. I know, surprise, surprise, and it's called AGE. Your embryo quality has everything to do with literally your age, your genetics, and your environment. Unfortunately, there are a couple of things we can't control. We can't control how old you are. We just can't. However, if you have the ability to freeze eggs or freeze sperm ahead of time, remember it's always nice to have eggs on ice. It's always nice to have sperm on ice, and it's awfully nice to have embryos on ice, especially when you're older. So if you're not in that situation and you can't go back in time and do those things, that's okay. The one thing that you can control is your environment. Sleeping well, exercising most days of the week, having a diet rich in antioxidants, and following an anti-inflammatory type diet, avoiding the environmental toxins that you guys all know about, like plastics, and there's a whole list of that kind of stuff. So those are the things that are in our control that we can do to improve our embryo quality. So that's the ability of a day 3 embryo to turn into a blast. And I have all of the, egg quality stuff that I talk about all the time, and I know you can find it easily on my website. But that's my message to you, Nikki, is look at what's in your control and see what you can do to change that as far as diet, exercise, lifestyle, because I feel like sometimes I'm a lifestyle medicine doctor, and sometimes I'm a little religious too. I say things like convert to Mormonism. I actually say that quite a bit. So no hard liquor, no vaping, no THC for you. If something looks like a gummy bear, say no. If someone slips you something that looks like a gummy bear, even the ear of a gummy bear, just say no. No gummy bears. This next question comes from Sky. Sky says, "Hi, Dr. Amy. My husband and I have been trying for almost 2 years. I'm 29 and my cycles are 26 to 38 days. No history of endometriosis or PCOS. My numbers are like this. Day 21 progesterone, 9 and 11 on a previous cycle. My prolactin 13, my FSH is 6, my AMH is 1.9. Antral follicle count 18 with a 16 millimeter dominant follicle on day 15 and endometrial lining of 7 on day 15. HSG is normal. My husband, 32 years old, abnormal sperm motility. He's had 2 tests done. Count is 49 million, 36 million, total motility 25% and 37%, with progressive motility at 20% and 17%. Here's the question. What would you recommend as the next least invasive option? We've only tried naturally. I've been told that the semen analysis is not that bad, and we're being recommended to take Clomid. If everything points to the fact that I'm ovulating, why take a medication for a problem I don't have? I'm going to ask for a sperm DNA fragmentation test, Sky. Sky, you are so right to ask this question. Remember, diagnosis before treatment. So let's figure this out. Your diagnosis is that you're a healthy 29-year-old with a good, healthy egg count at 1.9, which is your AMH, and your follicle count is really good at 18. It seems like you have something that's really common, and that's called male factor infertility because the sperm motility is a little bit low. So you're right. Diagnosis before treatment. Male factor infertility, go to the BALLS method, and let's figure that out. So step 1, sperm DNA fragmentation. Let's do that. I totally agree with that. Number 2, maybe have him see a urologist. So that's a guy that looks under the hood, and then I don't know how he does it actually, and he'll squeeze the balls and see if there is a varicocele. Don't tell your husband that they do that. They might not want to go. But honestly, we get poked and probed so much as women. Just having a testicular exam is actually, in all seriousness, really important. especially for young people. A varicocelectomy can take about 9 months to see an improvement in the sperm count. And let's say if you were 39, you wouldn't, you'd be like, 9 months? But at 29, you're like, cool, 9 months. I mean, I know it's still a pain in the ovaries to wait 9 months. Get it? Pain in the ovaries. Kind of funny. Not really. But you know what I mean. So varicocele, yes or no? Testosterone level, good or bad? There are things that you can do to improve a testosterone level, not by taking testosterone, but by taking other drugs like Clomid, Arimidex, Gonal-f, HCG shots. There's lots of stuff that we can do for sperm to make them sparkle and to move really, really fast. And then the other thing is to look at supplements, look at his diet, all that lifestyle stuff that I'm always talking about. Say no to gummy bears and no to hard alcohol and no to vaping. It's all bad stuff. And try and avoid heat exposure as much as you can. So let's just say your doctor is like, but I think Clomid. Then you say, but what about Femara? Because Clomid, I heard, will turn me into a clo monster. And I know some people actually hate Femara as well, and I totally get it. Femara is also something that can make people have brain side effects, mood swings. I mean, all hormones can do that. But if you were to compare the two, most patients actually have a better side effect profile with Femara over Clomid. So why would Clomid or Femara help someone with male factor infertility? Well, if you think about it, the more targets you point at, the higher the chance that you're going to hit one of them, right? So that's the idea behind it. So by helping you ovulate, even though you don't have an ovulation issue, it's simply a numbers game. 2 eggs is better than 1. It's like 2 tries in 1 cycle. And by getting them both there at the same time, the sperm can then have a higher chance of fertilizing one of them. And you can do that with or without insemination, but I would say with the sperm motility being just so slightly low, get them sparkling clean, get them attached to a catheter, get that catheter all the way up to the top of your uterus, push the end of the plunger, and now you have an intrauterine insemination. And ask your doctor if they have something in their office called Zymot Fertility. It's a little chip. I use it for my IUI cycles, and it seems to be going really, really well. And I feel like more fertility doctors will be doing it out there very, very soon. So that's another way of helping the sperm sparkle even more before an IUI. This next question comes from Fosent. Fosent says, please kindly assist me to understand PCOS. How can one get pregnant with it? Do you have any recommendations on food? What other illnesses I might be at risk to have with a PCOS diagnosis? I'm 25 years old and I'd love to better understand what the diagnosis means for me. So Fosent, first of all, I'll help you understand it. I call it HOPE syndrome. Let's break it down. HOPE, right? Because when you are told you have PCOS, I hear this all the time. Patients are like, I was told I would never have kids, and that made me depressed for like the last 20 years. And now I'm seeing you, and you're the first person that tells me that it's not as depressing as as they told me. And I had someone the other day tell me that she was diagnosed with it as a teenager, and they told her that literally she would never have kids. So that's why I call it HOPE syndrome. And so the HOPE stands for high testosterone levels, lots of eggs on the ovaries, periods that are irregular, and you got to pay attention to eating and exercise. So you got to balance it out from a young age so that by the time you're ready to have kids, you're not going to have as much of a problem. And then when you're older, you're not going to have as many issues that some people might have with PCOS that don't treat it and don't balance the hormones. So with the high testosterone level, you can take nutraceuticals or supplements like Ovasitol, lipoic acid, and acetylcysteine. You can take metformin, birth control pills to keep your periods regular. And you can follow a plant-based diet or, there are a lot of different diets out there. Basically, the diet that you can follow is the best one for you. And then exercising or moving your body and being your version of healthy is really important. So those are basically my tips for PCOS patients. And certainly there's things that you're at higher risk for if you don't have regular periods, like, some abnormal cells in the uterus, maybe some abnormal cells in the breast. I don't want to say things that are scary for people. Maybe some issues with cardiovascular issues, later in life. So that's why PCOS is something that I'm very passionate about educating people about from a very young age. It just gets me all fired up when people come to me, let's say they're 40 years old, and I'm the first one to tell them that they have PCOS. And now I have to spend all this time basically getting them to the point where I need them to be to get pregnant, which is frustrating because they could have, been told a lot earlier and had very basic, simple tests done. There's a lot of doctors that are very experienced at dealing with patients who have PCOS and all the issues that are there. And the last thing patients with PCOS should be thinking is that PCOS is just something you treat when you're ready to get pregnant. That's incredibly unfair and untrue. Okay, I'm off my soapbox now. So this next question comes from Kian. I'm 33 years old, diagnosed with a balanced chromosomal translocation. My AMH was 1.9 when I was 30. I had 4 egg retrievals. The first time was in 2018. I had 13 eggs, 3 blasts. Second time was also in 2018, 9 eggs, 3 blasts. Third time was in 2020, 6 eggs, 1 blast. Fourth time was in January 2021, 8 eggs, no blast. I'm kind of desperate. All blastocysts underwent PGD and only 2 are normal. I transferred the first blast in 2019, but I had a miscarriage at 9 weeks. Second implantation was a failure. With less and less eggs retrieved, I just really don't know what to do. Is mini IVF a feasible solution for me? The doctor suggests that my egg quality may not be good enough. I'm really sorry that you're going through this, and your case is considered a very challenging case for IVF doctors everywhere. This is something we talk about, and we wish we had better tools in our toolbox to help patients just like you. It's heartbreaking to go through as much as you went through and then to still transfer and have a miscarriage, or transfer and have it not work. So aside from asking your doctor about the quality of those 2 embryos, I think that would be really helpful for you to know. So you really know as much about why the embryos didn't work. Talk to your doctor about doing implantation testing. For example, the ERA test and the Receptiva DX test. See if they think that those could play a role in helping you and help understand what to do next. I also recommend the egg quality supplements and the lifestyle changes that I'm always talking about. And look at sperm quality as well. Consider doing a sperm DNA fragmentation test and see if that will help you. Both the male and female sperm source and egg source should also be focusing on not just us as women. We should also be focusing on healthy lifestyle and doing what we can to boost sperm quality as well, because we know an embryo is literally half an egg and half a sperm. I think that doing mini IVF and trying other approaches is a good thing to do. I don't think you have to give up on your own DNA. As long as you are making mature eggs, it's obviously really sad that you didn't get any blasts in this last cycle, but sometimes that can happen. And I've seen it happen for patients of mine as well. And then we go do another cycle and we have a gorgeous set of blastocysts. So don't give up quite yet. Consider HGH, other types of protocols. See what your doctor thinks about maybe adding FSH to your trigger shot, potentially, if there's any other technology in the lab like calcium activation that they think might help, see what they say. And I hope this next cycle works for you. This next question comes from Sandra. And it sounds like I just swallowed something. Not sure though. Okay. Okay, here we go. Sandra says, "Hi, Dr. Amy. I'm 37 years old. I've been trying for over 2 years. I've been going to Northwestern Fertility Center, and so far everything looked normal except my elevated prolactin at 66. My AMH level is 0.78. Unfortunately, we had to stop trying to conceive because my husband was diagnosed with non-Hodgkin's lymphoma. Everything happened so fast that we didn't have time to save a specimen from him. I'm very sad to think that we may never have kids, but my oncologist told us that we should wait and do a semen analysis. They said that it's possible that his sperm may recuperate. What do you think I should do? Due to my age and low AMH, plus my elevated prolactin, I don't know what to do now. My insurance covers IVF, which is good. I'm so overwhelmed by everything. By the way, my husband is doing great and recuperating. Thanks in advance. You're an angel." So Sandra, you're 37, your AMH is 0.78. Let's get some eggs on ice. Okay, let's do it. Let's do it right now. You have the coverage for it. Go make it happen. Do maybe 3 or 4 egg freezes, because once your husband, if hopefully, his sperm comes back, once it does, it might be lower quality. You might have to potentially extract it. Let's see what we find out. But because the sperm quality might be low, you might need a lot more eggs to get really healthy embryos. And, it might be a good idea to start talking about creative family building, what I mean by that. And I know everyone wants a baby, most people, with their own eggs and own sperm, but sometimes things happen in life and you have to learn from it and then ask yourself the 3 questions. What do I want? What is it going to take? Am I willing to do it? And given the situation that you're in with your AMH and your age, I think it would make perfect sense potentially to maybe freeze 2 sets of eggs and maybe do a 3rd set with donor sperm. Maybe he has a sibling. maybe there's another family member on his side of the family who could donate for you guys. That's something to potentially think about. And I hope my advice is helpful. And I've definitely seen guys in the same situation that you're in regenerate sperm later, even 6 months, a year, 2 years later. I've definitely seen it. But I think most of the time you shouldn't expect that to happen. This next question comes from Daisy. And Daisy says, I'm 41 years old. My AMH is 0.8, FSH is 6, estradiol less than 50, TSH is 1.7, prolactin is 6, A1C is 5.7, first child at 38 after trying for 1 year. I was scheduled for priming and stem in February and an FET in May. I'm nervous. Tushy and balls, all good. Sperm DNA fragmentation test pending. Diagnosis is advanced maternal age and decreased ovarian reserve. Should I consider IUI or go straight to IVF for 1 cycle or 2? I only want 1 more child. Help. Ready to do what it takes. Thank you. Love you. So Daisy, I'm going to be the bossy fertility boss that I am over here, and I'm going to say go right to IVF. I don't necessarily think you have decreased ovarian reserve. Honestly, your levels at 41 are fan-freaking-tastic. An AMH of 0.8 and an FSH of 6? Holy smokes! You could potentially get 8 to 10 eggs if these levels are consistent with what your follicle count shows. So I always tell people, once you're 37 or above, even if you already have 1 baby at home and you want a second, do whatever you can to be as aggressive as you feel comfortable being. And you said IVF, so if you feel comfortable with that, do it. You have plenty of time to do other things. There's plenty of time to do IUI if your IVF cycles don't work. But I would say right now, with all the numbers that you're sharing with me, IVF is exactly what I would recommend if you were a patient of mine. This next question comes from Argelia. I'm 39 years old with an AMH of 1.24, FSH of 4. I was diagnosed with anovulation. My husband's 40, seemingly normal semen analysis. I'm taking CoQ10 prenatals, a vitamin D. I have an 11-year-old daughter with autism and developmental delays. She was conceived naturally. I have egg retrieval in January, and I got 11 eggs, and out of 11, 5 were mature and 5 fertilized. I got my report on day 5, and 1 was an early blast, and on day 6, that 1 went for PGTA. I want to know what my options are at this point. I'm feeling not very hopeful and need advice for you. Would you recommend to do another retrieval or wait and do the transfer if the PGTA is normal? So this is the question. My question for you is, how many kids do you want? And I think what you might have shared, let me see here. Did you share with me? I can't tell if you want just 1 more baby or you'd be open to more. I mean, without knowing your PGTA results, it's so hard to know what to do next. And I totally get it. Our minds and our heads and our hearts, they're just like spinning and spinning and spinning. Like if this, then that, if this, then that, if this, then that. I mean, that's just a lot of stuff. And you know, it makes sense to be just constantly consumed with the decisions that we may need to make or not. And I wish I could like take, you know, when you go to the grocery store and they just, you know, run your embryo over something and it's like, deep, and you're like, you know, normal, or this is the chromosomal abnormality. Wouldn't it be great if we had a tool like that? And we don't. And until then, you know, I would say make the decision based on the embryo quality. So if your embryo quality is low, perhaps don't put your energy into transferring this one. Potentially consider doing another cycle. Or sometimes if you need time, I would say since there's 1 embryo, consider doing your mock cycle now. So do your ERA month and get that taken care of so that you have the information, and then by then you'll have a decision as to what you want to do next. But it's hard for me to really tell you to do another cycle or to go right into transfer. I think it's just really based on how many children you want, how many more, and the implantation rate of this embryo, and that's based on the embryo quality. And then obviously the one big picture piece of information, that one puzzle piece we really need, and that's whether this embryo is genetically normal or not. Okay, so this next question is from Kay. Kay says, I'm 41 years old and I've had multiple canceled cycles due to poor response. I've had between 6 to 7 follicles at baselines, but after several days of stem, I'm always down to just 1. What causes my follicles to disappear? And what can I do to recruit more? Okay, I swear this is something that I deal with often too. So one of the things that can be happening is this. We're frying your eggs. You've heard that saying before. I mean, I don't literally think that that's a thing, but I've seen it. Like, I see a patient, she has a whole bunch of eggs, and then I do straight injectables, and then I don't see any eggs anymore. And I see a far lower number. And I just get slightly annoyed. And slightly is just, a huge understatement. So one of the things that I think could help in a case like yours, one of a couple things that I'll bring up, is one, don't start with straight shots. Perhaps consider starting with fertility pills and then add the injectables later. And you guys all know I'm not a fan of Clomid. I'm a fan of Femara just because of the side effects. So maybe take 3 or 4 tablets a day for 5 nights, then go back in after 2 nights of shots. Perhaps start your shots after the 3rd day of the Femara. There are different ways of doing things, and see what your doctor is more comfortable with. And the other thing is, you guys hear me talking about waves of eggs just like I'm some surfer sitting at the beach all day, which I'm totally not. And that might be another approach. So rather than starting stim at the beginning of the cycle, perhaps start after ovulation this next time. Okay, this next question comes from Sheeding. Sheeding says, thank you so much for all you do, Dr. Amy. I'm 36.75 years old, and I've had 2 miscarriages. And Sheeding, I'm sorry that you had to experience that. I had my Tushy checked, including the Receptiva DX test. All tests came back normal, except I have fibroids. Last fall, I had a hysteroscopy done to remove a very small submucosal fibroid that was less than 1 centimeter. It had indented the endometrial stripe. Last month, I found out this fibroid is back and making a dent on my lining again. I had my first IVF done last year and was lucky to have 4 PGT tested embryos. 2 are excellent and 2 are good. My AMH was 2.25 about 3 months ago. I'm wondering if I should do another round of IVF with hopes to bank more embryos. I would like to have at least 2 to 3 children, and wondering if I should do another hysteroscopic procedure before transfer or have a laparoscopic myomectomy instead. Are there any hormonal treatments you would recommend in addition to the surgery? Thank you. Okay, so Sheeding, here are my thoughts. You want 3 kids. You have 4 embryos. Let's do 1 more cycle of IVF to get you more. I would do the IVF first, then remove the fibroid second, and you can do a hysteroscopic myomectomy. If it's 1 centimeter inside the cavity, it doesn't seem like a laparoscopic myomectomy would make sense. No need to have that slightly additional longer recovery time. I think you can go right into a hysteroscopic myomectomy right before your transfer. As far as other hormonal treatments, I mean, I feel like your egg quality is really good. I'm not sure what your fertility diagnosis is overall, but the implantation issues, right? Issues, that's a good word. The issues that fibroids inside the cavity can cause could have been everything that you have been dealing with. So my suggestion, IVF, hysteroscopy, and transfer. And it sounds like you've done a lot of testing so far, but ask your doctor if you should also consider the ERA test. And perhaps you can do that test, and I'm doing this because you could do the biopsy at the same time as your next hysteroscopy. Okay? I hope this was helpful for you. This next question comes from Ashley. Ashley says, hi, Dr. Amy. I'm 28 in a same-sex relationship with my lovely wife who's 28 also. We just had our first consult, and I will be the carrier of the babies. Our doctor isn't sure if my adenomyosis is enough of an issue to require Medicare assistance or rebate, which means our costs more than double. This is really disheartening, and I'm anxious that saving the money right might mean 2 years until we can try, and my eggs will only continue to age, with adenomyosis potentially causing issues for implantation. I really want to do IVF so that our kids will have the same sperm donor. IUI is cheaper, but there's no guarantee that the donor will be available. My eggs will continue to age in between tries. My wife and I don't know if it's worth it to phone a friend to donate, but the legalities and the fact that we don't know if we have any friends who'd be willing, and my wife's feelings of not being a more authentic parent of a child whose donor is known, make me reluctant. Help. Okay, so Ashley, I would suggest doing the following. Get more data. Pelvic MRI. Let's get that on paper that you have adenomyosis. HSG. Potentially, not that I'm hoping that your fallopian tubes are blocked, but sometimes there are things that you can see in the fallopian tubes when someone has adenomyosis. Sometimes it also means they have endometriosis, and that can affect fallopian tubes and cause some peritubal scarring and adhesions that you can see on HSG. I think all this information with your doctor's diagnosis, a pelvic MRI report, an HSG report would all make it so that hopefully you would get the coverage that you deserve, to have the family that you deserve as well. We know that adenomyosis and endometriosis are fertility-threatening conditions. Adenomyosis can decrease our implantation rate, and endometriosis can increase our egg age and make our eggs older than our chronological age. My suggestion to you is to do what you're thinking from the very beginning, which is to bank embryos for your future and start transferring as soon as possible. Ask your doctor if you should be taking Depo-Lupron before transfer. That's something that I would talk to my patients about. And then consider going on birth control pills immediately after delivery, and consider taking it continuously to prevent progression of your adenomyosis. Unfortunately, sometimes even when you do that, it can still progress. And see if you need a laparoscopy before transfer to help increase your chances of a healthy implantation, pregnancy, and delivery. This next question comes from Diana. Diana says, "Hi, Dr. Amy. I'm writing you from far, far Hungary. So happy I discovered you. I'm 37 years old. My AMH is 1.1. My FSH, LH are normal. My follicle count's 14. I had stage 4 endometriosis surgery in 2016, and we've been trying to conceive for 1 year. We had an IVF in December. Stem was 300 of Pergoveris, only 4 eggs retrieved, and only 1 embryo turned into a blast, but did not stick around. I'm very surprised about having only eggs to retrieve, given my AMH and all hormones are normal. My husband has perfect sperm conditions, all eggs fertilized with normal IVF, and in this month's natural cycle, I had follicle count of 14, but no ovulation. All of them stayed around 10 to 12 millimeters. I have very light periods lasting no more than 2 days, and for me, it looks like something is holding back egg production. I'm aware of an endometrial cyst in my left ovary, 14 millimeters. My specialist says not to touch it. My IVF doctor wants to do a long protocol now. What do you think? Should I do surgery first and then IVF? Maybe a long protocol? Thank you." So here's the thing. What you're experiencing is very, very common among women who have endometriosis. Endometriosis can decrease our egg quality. Endometriosis can affect our blast formation rate. Endometriosis can also affect our implantation rate. And it sounds like you're dealing with all of those things. And for that, I'm very sorry. So my recommendation is to keep trying, try different approaches, and trust your doctor, listen to what their suggestions are. I imagine they also have a lot of experience in patients who have endometriosis. But at the same time, I don't want to miss something else. What if this actually isn't endometriosis? What if the reason the embryos aren't reaching the blastocyst stage, or the reason why the embryo didn't implant, is because of a genetic issue that we're missing? So I know your husband's sperm is awesome. We know your egg information, but make sure you've done a chromosome analysis on both of you. That's just one small suggestion that I would have. And then as far as doing another laparoscopy versus doing IVF next, or doing another IVF and then doing a laparoscopy, my thoughts are this. Let's look at your AMH level again. Your last AMH was 1.1 when you were 37 years old. There are some fabulous endometriosis doctors out there, and I bet you had one too in 2016. So go back to that doctor and see what they think. See if in their experience in a case like yours, that after doing surgery, you would see an increase in your fertility. So talk to them about that and take CoQ10 and acetylcysteine. Make sure you're on a good prenatal with vitamin D and fish oil, and see what else your doctor suggests as far as other lifestyle stuff that could benefit you. But I would say that endometriosis, I wish we had better tools to treat. I have a doc coming on here. I already did the interview, and I can't wait to share that interview with you. His name is Dr. Kevin Osteen, and he talks about endometriosis and different novel therapies that hopefully will be coming soon. But for now, all we have are the things that I talk about on the show, like diagnostic tests that you can do, surgery, medications like Depo-Lupron, Orilissa, birth control pills. But I still feel like there is a chance for you. And I would say talk to your doctor about different approaches to IVF and why they're choosing those protocols and what they're hoping to gain. And if you're somewhere, and I think you said you're from Hungary, if HGH is something that you could try, consider doing that too. And then the other thing, my other last tip for you is Femara is something, or letrozole, is something that I use in my IVF cycles for patients who have a history of endometriosis. You basically take it every single day until your trigger shot, and that keeps the estrogen away. It doesn't prevent your eggs from growing. It can be confusing for people because when you take it, it keeps your estrogen levels really, really low. And one of the things we like to follow in IVF are estrogen levels. What you guys should know is before ultrasound, estrogen levels were basically the only thing we had to guide us about how the eggs grew during IVF. And now that we have ultrasound, we actually probably don't even need any estrogen checking throughout a cycle. We still do it when patients are on Femara, but I always tell people, listen, like Femara will make your estrogen undetectable, so don't be tripping that your estrogen level is super, super low throughout the cycle. It doesn't mean that you're not growing gorgeous, mature, sparkly eggs, okay? This next question comes from Mia. Mia says, I have 5 children. My youngest is 12, and I did a tubal ligation in 2010. And 4 years ago, my tubes reversed, and since then, I've had 11 miscarriages. Last pregnancy was an ectopic. I keep losing them at 6 weeks, and I don't know what to do. Please, can you help? So, Mia, here's the deal. You might not be having miscarriages. You might be having recurrent ectopics every single time. However, if this is a new partner, let's just get his sperm checked, do a DNA fragmentation test on him, look at his chromosomes, and make sure that this isn't from the sperm side of things. And I would consider doing an HSG because it sounds like your tubes might be trouble. And I don't want you to do an IVF cycle with genetic testing, transfer, and then have another ectopic again. So my suggestion to you is to get your AMH level checked, look at all the sperm stuff, do another HSG, and consider moving on from trying naturally, and let's do IVF. I know you worked so hard to get those tubes reversed, but it seems like they're not really helping as much if you keep having abnormal pregnancies or pregnancies of unknown location, and that's kind of hard to deal with right now, especially with COVID and the pandemic. You just don't want emergencies as much as possible. And an ectopic pregnancy can sometimes turn into an emergency or trips unnecessarily to the ER. And I say unnecessarily because if you know what's causing the ectopic and it's an abnormal tube, we should deal with the tube before you have another pregnancy. This next question comes from Danny Ray. Hello, you're an angel on this planet. Thank you for all you do. I'm recently 39 years old, 4.5 years of secondary infertility, 3 medicated timed IUI, 3 medicated cycles, 6 IUIs, 1 IUI canceled because I had 9 large follicles, 2 retrievals, 3 transfers, 2 fresh, 1 frozen. And after all of that, only 1 chemical pregnancy from the day 5 fresh transfer. First retrieval, 11 eggs, 4 embryos, and only 1 made it to day 3. Failed transfer of a very poor quality embryo. In the recent retrieval, I had 33 eggs, 9 fertilized, 7 frozen day 5, and 1 fresh day 5. Transfer turned into a chemical pregnancy. After the chemical, we did a frozen transfer using birth control and 16 days of Lupron, Neupogen, estrogen pills and cream, progesterone injections and cream, Lovenox and aspirin, CoQ10 full TX, vitamin D prenatal, L-arginine, acupuncture, 1 week for a month, or once a week for a month. And then I transferred 2 embryos and they both failed. For my upcoming transfer, March 5th, do you have any advice or recommendations? I do. You know I do. So Danny, let's figure this out. So number 1, you mentioned that you have secondary infertility. So we know you've had a pregnancy before. So number 2, part of your diagnosis is that you've had chemical pregnancies. Okay, so let's set that aside too. So age 39, chemical pregnancies, previous pregnancy. And then the other thing that we know is that even besides the chemical pregnancy, you have another, transfers that didn't work. So my question is this: have you done genetic testing on the embryos, yes or no? The likelihood of an embryo at the age of 39 having normal chromosomes is around 25%. So it's not like it's one of those things where 1 out of 4 should be normal. Sometimes it turns out that all 4 are not normal. So I'm just not sure if you've done genetic testing of your embryos, yes or no. Let's just assume you have not. So let's make the assumption, even though we don't know, that, what am I trying to say? Let's make the assumption that these embryos are actually normal. And what would I do? And then I'll make the assumption that that they were normal and the chemical pregnancy happened despite them being normal. Okay, clearly I'm thinking about something else, and I'll tell you guys what I'm thinking here in a second because it's pretty funny. And not to do with Danny Ray, because whatever you're going through obviously is not funny. So I don't mean to say that, but Danny Ray, I promise you, you're going to laugh so hard that you're going to just maybe fall off your chair. So here's my point. My point is this. When you've had chemical pregnancies, fresh transfer, frozen transfer, we want to find out why. The implantation issues you're having could be due to a hydrosalpinx. It could be due to, for example, being outside the implantation window or silent endometriosis. So you might want to consider talking to your doctor about the Angel method. So looking at the anatomy of your uterus, your fallopian tubes, rule out a uterine septum. Sounds like you probably don't have one, but I would still look at that. Look at an autoimmune issue. Make sure you've done the antiphospholipid antibody panel as an example. Ask your doctor if using Lovenox is something that you should consider in your situation. It sounds like your doctor has thought about lots of things. Subcutaneous Lupron, Neupogen, so they're thinking autoimmune. So I would say maybe even take it a step further and go, I don't like to call it the nuclear option, but maybe consider Depo-Lupron instead. So if there's no chance that you have, let's say, silent endometriosis and you've already done the testing, you've already talked about it, and there's no chance you have adenomyosis, you might still want to perhaps do 1 month of Depo-Lupron to see if that could help you and overlap that with another steroid like Femara. That might be one way to help with implantation. Your transfer is March 5th, so I kind of feel like a jerk bringing this up right now because your transfer is right around the corner, so I certainly don't want to put a kibosh on your plans. But if you guys aren't pregnant with this next transfer, which I hope you really, really are, perhaps you should consider doing genetic testing with your next embryo transfer. So this is the funny thing that just kept coming into my head. And I'm going to say it, and then I'm going to be embarrassed for myself. So something happened today, and it's very funny. And it has to do with cock jokes, literally. So I'm doing my transfer, and I'm sitting there, and then on each side, on her socks, it says I with a big heart, love, and then COCK. So what do I say? I'm like, oh my God, I cannot believe you're wearing I love cock socks. And then she says, Dr. Amy, I think you missed the word underneath cock, tails, right? I love cocktails. So I'm like, damn it. I just made a complete ass out of myself. So anyways, what I was going to say to you, Danny, is let it go. Find the funniest socks that you can find. Wear them that day. Know that you've done everything in your control to give yourself the best chance of pregnancy. And then just walk into that transfer. You know, maybe consider doing some acupuncture before and after. Have your husband sing to you on FaceTime. Make him promise. Tell him what song to sing and he can practice beforehand during the transfer just to, you know, keep the mood alive and fun. But anyways, that was the thing that was distracting me that I was thinking about. Cock jokes. So then I was like, maybe you can design like I love cocker spaniels. I love cocktails. I can't really think of other things to trick people with when it comes to fun socks that you can wear at a transfer to make your doctor look like an ass and completely blush. So anyways, I was like, this is very awkward. I'm standing here and watching, you know, doing my thing and like you have these socks. Anyways, it was a good time. We all had a good time. We were laughing, maybe crying, laughing so hard. Okay, this next question comes from Kathy. Kathy says, hello, Dr. Amy. I've gone through genetic testing and nothing came up. Would you recommend that my husband also do genetic testing? We do plan to PGTA test our embryos. Our IVF cycle is starting in a couple of weeks, and we want to make sure we have everything covered. P.S. My husband thinks your jokes are so funny. Well, I bet he's going to love my cock joke. I actually have another cock joke. Here we go. So this is like legit real. This is really a cock joke. So if you're a patient of mine, you guys know that I always email summaries after almost every meeting, whether it's in person, phone. It's like, that's my way of keeping accountable. Summary, done, send, follow up. You know, we always have a plan. If your period starts, think of me, come on in by cycle day 3. You know, like I come up with all this stuff to make sure people know what the next steps are, what my plan is for them. Okay. So I messaged a patient, take CoQ10, right? But I didn't verbally say it. I typed it out. I said, I want you to go to the pharmacy today, not today, but whenever, and take CoQ10, CoQ10. So next phone consult, this is legit. Dr. Amy? I'm like, yes. I went to the pharmacist and I said to him, I need cock to help with my fertility. I'm like, what are you talking about? She's like, cock. Like you wrote it in the email that I need to go get it. You guys, she meant CoQ10. I mean, literally, like, can I? So I said, no, just come to my office. I have it in my office. I'm going to give you a bottle. Like, you don't ever need to go and find it. And I didn't have the heart to tell her that it's CoQ10. Anyways, I hope this makes you laugh, or you'll be very embarrassed for me. This next question comes from, I actually got so distracted with my cock joke that I did not answer Kathy's question. So Kathy, here's the deal. Whether your husband does genetic testing or not, it doesn't matter. What I mean by that is you've done your panel. If you're negative for everything, whether he's positive for something, it's not that it doesn't matter. The likelihood of you guys passing on the same disease or that disease to your offspring is close to 0%. Nothing is 100% accurate, meaning like just, there are situations, I've had it happen once actually, where the husband tested negative for cystic fibrosis and the wife was positive, and they ended up having a baby that had 2 variants. It just wasn't picked up on that panel. So I can never say that I can 100% reassure anyone that they won't have a baby with a certain disease when they do this testing. But for the most part, these tests are really helpful in getting us as close to, 100% prevention of the diseases in the panel only. Whether you do PGTA or not has nothing to do with the gene testing. So PGTA looks at the chromosomes of the embryos. And so there's so many different analogies out there. So it's like one way of thinking about it is encyclopedia books. So you're looking at all the encyclopedia books when you're doing chromosome testing, and the gene testing looks at the different pages in the books ahead of time. And you can't look at the pages when you're doing the testing. You can only look at the encyclopedia books A through Z. So that's why it's important to know what page to look for ahead of time. And that's why we do the recessive gene screening first before you do IVF. And one of the things people always say to me is like, Dr. Amy, I don't have any of these diseases in my family, so why do I need to do this recessive gene testing? And I say, I know. That's why. It's because you don't have anyone in your family that has any of these diseases. So you and your husband could carry one of these diseases and just happen to fall in love with each other and then have a 25% chance of having a baby with one disease. So that's the reason behind it. Okay, this next question comes from Anna. And Anna says, recently in January, a study was published in Molecular Psychiatry that linked the presence of certain maternal autoantibodies with the development of autism in her offspring. Would you by any chance know if there's a way to get tested for specific autoantibodies that might affect a woman's fertility, pregnancy, or fetal development? Would it be something that a rheumatologist or RE deals with? And the answer is, Anna, I think I know exactly what study you're actually referring to. And I've actually had my own patients send me the same study, hoping that I would be able to offer them this type of study. And right now, this type of testing, not study, this type of testing is only done in research type settings, and it's not clinically available or clinically accessible. And I think the point that you bring up is the one thing that we always do is worry. We worry about our pregnancy. Is it going to be normal? Are there going to be birth defects? And then at the end, is our baby going to be autistic? And we don't have really good tools to prevent autism other than what I wish we could do as a society. And what I wish we could do is from the very beginning is when someone says, I want to try and get pregnant, all of a sudden you get signed up for a meal plan, antioxidant rich diet, organic, you get sent out the right, BPA free water bottles. Someone's coming to your house, checking all the HEPA filters, checking your faucets at home, doing heavy, like all sorts of testing around. Like, wouldn't that be a dream come true? And then in pregnancy, you have, a pregnancy meal delivery. And then, you're given time off in the first trimester rather than trying to hide your pregnancy from everybody because you're worried that someone at work is going to, do something, or you might lose your job. So you're working despite being stressed. You're working despite being potentially really sick to your stomach. And then, that's kind of like my dream is first trimester leave. I feel like if we can decrease stress, reduce exposure to toxins, viruses, potentially we can also have healthier pregnancies. This would decrease preeclampsia, decrease preterm labor, and those two conditions actually increase autism rates. So I wish that someone would create a fertility surgeon general position, right? I wish. And then I could be the big boss, and then I could create all this kind of stuff, and then all my dreams would come true for all of you. But until then, I just have to sit here and talk about it. Maybe someone will listen one day. But until then, I can keep dreaming. This next question comes from Cassandra. Cassandra says, hi, Dr. Amy. I'm 36. My husband's 42. We have one son who is 10 years old. We've been trying to conceive for the last 2.5 years. I had an ectopic in 2018. I'm slightly overweight. My TSH is elevated. My fertility doctor prescribed 50 micrograms of Synthroid to correct my levels. My husband had a semen analysis and his numbers were great, but his morphology a little abnormal. My tubes are clear, cycles are regular. I'm not ovulating on my own. I did 4 rounds of Clomid with my OBGYN, not successful. We started seeing a fertility doctor in November. My doctor said my eggs are good quality and decent quantity for my age. We're in our second round of timed intercourse, Clomid 100, Gonal-F 150, and the trigger shot. My first cycle, I had 1 mature follicle, and my second, I had 2. They confirmed I ovulated, but we're still not pregnant. Should we try 1 more round of timed intercourse before IUI or go to IVF? So Cassandra, here's what I would say. If you guys had an ectopic pregnancy, it's like, could that be the reason why this is happening? I know you said you had your tubes checked and they were clear, but I'm still suspicious of your tubes. Whenever I have a young woman who's been trying for as long as you, especially with a history of an ectopic, I'm just like, there might be something still wrong with those fallopian tubes. And your doctor's right. There might not be anything wrong with egg quality. Maybe the sperm morphology is a little bit low, but overall, if the count is really good, you still could be in good position to, let's say, do IUI. But here's the thing. If you know which side your ectopic pregnancy was on, I don't know if you remember that from 2018, but I imagine you would, perhaps be a little bit more aggressive and do IUI in the cycles where you're ovulating on the other side, right? So let's say you had the ectopic on the left, try and focus on doing IUI in a cycle where you might be ovulating from the right. And then I would say, if let's say the next couple cycles don't work, then it's very possible that there might be just some issue at the meeting place between the egg and the sperm, and that embryo transport system just isn't doing its job. So I would consider at that point doing IVF. And if his morphology is low, see what you can do to get his morphology up. Get it up? Anyways, thanks for asking that question, Cassandra. That's a really good one. So this next question is from Anna. Anna says, hi, Dr. Amy. Thank you so much for providing a forum to ask our questions. Does testing positive for ANA affect a woman's fertility or her ability to carry a healthy pregnancy? What kind of preconception testing, if any, would be recommended for someone who has very high titers of ANA? So Anna, I'm going to take a drink of my coffee right now because I noticed that it sounds like I'm going through puberty. This is what happens when you're talking starting at like 6 in the morning. I have to tell you guys something funny. I see patients all day, right? And then I always call my husband, I'm going to do my Instagram live. I'm like, what are you doing? And he's like, I'm running in the sand dunes. I'm like, what? I'm running in the sand dunes. I'm like, where the hell are the sand dunes? Like, huh? And he sounded like he was running and I didn't know what he was talking about. Anyways, he was on the treadmill. So next time, it's like, whoo, joke way over my head. That that wasn't even a joke. He was literally telling me he was running on the sand dunes, but he meant his treadmill. But I thought that was just kind of funny. Okay. So Anna, to answer your question about ANA, so the ANA test is a very non-specific test. It is a test that I do on my patients who have recurrent miscarriages. It isn't on my checklist. It's not like Tushy-ah, it's like Tushy and there's no A at the end. So it isn't a test I generally do for people. However, if your ANA is high, especially very, very high, there is a list of labs that you want to do. And I often ask my patients to go see a rheumatologist. We live in a society, especially here in the Bay Area, where you have access to so many experts. So there's a list of stuff, just like I mentioned, like lupus anticoagulant, anti-Smith, anti-Rho, dsDNA. There's a whole bunch of stuff that we do to make sure that we're not missing another rheumatologic disease. Let's say that panel comes back completely negative. You don't have any joint pains. I would say it could just be a false positive. And there's really nothing else that you need to do because it could be elevated for a whole bunch of reasons that have nothing to do with your fertility or even your general health. I know it's like, what? you see something that's positive, and sometimes it makes us really anxious and worried. But when it comes to a test like that, it may not be something to worry about. But I would definitely see an expert. Don't rely on a fertility doctor to tell you if you're worried, okay? This next question comes from Shruti. I'm 33. My husband is 38. We've been trying for 10 years. 2 IUIs have been done, and now I'm going on to IVF. My husband's morphology was less than 1% normal. His count's 85 million. Is morphology an issue? 7 eggs were retrieved. My AMH is 1.4. We got 6 fertilized, all blasts. 3 embryos are AA, and 4 are day 6 early blast. So what are our chances of conceiving? My doctor is saying she'll put 2 AA embryos first, and if not succeed, then we'll do 1 AA and 3 day 6 blasts. Oh! What are the chances of a healthy pregnancy, and how would you recommend we proceed? Holy smokes. Wow. Okay, so I'll just tell you what us docs do around here, okay? Transfer 1 AA first. If it doesn't work, transfer another 1 AA. I mean, not that it's a 1, but another AA second. If that doesn't work, then consider transferring 2. Most of us would never imagine transferring 2 and then the next time transferring 4. So my recommendation for you is to ask your doctor, what's the implantation rate per embryo? Why do they recommend transferring 2 embryos, especially when they're so gorgeous, given the high chance of twins and all the complications that can potentially come from having a twin pregnancy? So goal is 1 healthy baby and 1 healthy mama, and twin pregnancies can be great and you can have no issues and everything can work out really well. But when it doesn't, it can be a complete, and I'm going to say it can be a complete shit show. And I've actually said that to a patient. I said that the other day. And she goes, well, Dr. Amy, I'm a twin. And I'm like, well, I didn't call you a shit show. I just mean in general. So when something bad happens in a twin pregnancy, I literally, I know the patient's name. I remember the date it happened. It affects me very deeply. And so that's why I just, I say things like that, because obviously people will remember it and they'll be like, no shit show for me. But then when someone tells you that they're also a twin, well, my mom was a twin, my dad was a twin, and I'm like, okay, fine. Still, I don't want you to transfer too. This next question comes from Sarah. Thank you for being so helpful. We've been trying for more than 3 years with 1 6-week loss last year. I'm 31 years old. In 2019, my AMH was tested twice. 1.4 and 1.07, my FSH was 6. A hysteroscopy showed chronic endometritis after the miscarriage, and we treated that. Blood work for overall health and a saline sono, all checked out. My husband had chronic prostatitis twice in the last couple years and has been treated with 3 types of antibiotics. Current numbers are 48 million, 69% motility, 4% morphology. We're both on supplements you suggest. A specialist here in Switzerland agreed on the following plan. The plan is this: 3 medicated IUIs, then a natural IVF cycle, then a mini IVF cycle, then full stem. I'm frustrated. Should I follow that given plan that can take forever, or keep looking for a specialist to jump straight to IVF? Thank you so much. I'm frustrated too, Sarah. I wonder if the infection that caused the prostatitis also gave you the chronic endometritis. That's one thing that I'm thinking. The other thing is that, since 2019, if you've been trying, especially when you've had a miscarriage, it's like my heart is just breaking for you. And so obviously I totally get what you're saying and why you're saying it. And I agree. I would start full stem first, get your embryos made, transfer, and then hopefully you'll live happily ever after. But the amount of time that it would take to go from 3 IUIs, natural IVF, mini IVF, then full stem, that could be 2 years. So I highly recommend that you advocate for yourself and you ask the doctors for what you think is important to you because of the answers to the 3 questions. What do I want? What is it going to take? And am I willing to do it? And given your age of 31 and the number of years that you've already been trying and what's going on, I think it makes complete sense to go the direction that you think is right for you. And then also, I'm sure you've done all this testing already, but perhaps look at the Angel Method or Angel Checklist on my website, angelmethod.com, and see that you've done all those tests up front before your IVF cycle. Okay, this next question is from Ashley. And Ashley is asking, I'm 38 years old with an AMH of 0.2. I recently had a laparoscopy completed for endometriosis, in which we learned that the left ovary is almost completely covered in the left tube. It had to go. I just started 3 months of Depo-Lupron. I'm currently taking prenatals omega, acai berry, pterostilbene, Tru Niagen, vitamin D, and CoQ10. I bet you guys, if you guys have been watching, you're never going to think of or listening CoQ10 the same. I stopped taking melatonin as I've heard it can interfere with my synthroid. My doctor does not advise I start DHEA. I've had the Whole30 and Mediterranean diet advised, but I'm not sure that altering my diet aside from eating healthier is best. What can or should I be doing during these 3 months to help give us the best chance possible when we're able to start cycling for IVF again in late April or May? I'm so grateful for your show and the information you share. Thanks, Ashley. All right, here's the thing. I don't know if you already did 3 months of Depo-Lupron or not, but if you haven't, stop. And what I mean by that is just if you've already gotten 1 month in your system, don't sign up for 2 more months. If you've signed up for the 3-month shot and there's no going back, don't worry about it. Okay? My goal for patients just like you is make embryos first. The Depo-Lupron can come later. With your AMH of 0.2, I just worry that the amount of time from now until when you're ready to cycle again, maybe in 4 months, that might be just so much time, and it would be so much harder to get healthy eggs from you at 38 years old. You see what I mean? So again, if the shot is a 1 month at a time shot for 3 months, great. Don't take shot number 2 or number 3. If you've gotten that 3-month shot in your arm, don't worry about it. Just let it go. And then I would stimulate as soon as that shot is out of your system. And, there are some doctors actually. I think I actually met a doctor who was able to stimulate a patient on the Depo version, but it might just not be such a good idea because your AMH is 0.2. So my suggestion is, as far as melatonin, it is safe for my patients to take if your thyroid is well controlled. And when you're on Depo-Lupron, I can tell you it's really hard to sleep. That's the number one symptom that my patients report, which is severe insomnia. So you can ask your doctor for Ambien, for example, Lunesta, Unisom. You can get Tylenol PM and Unisom without a prescription. But whatever you need to do to get good sleep, I think is really important so you don't lose your mind on the Depo-Lupron. Diet, I think, is really important when you're on Depo-Lupron because it can make you feel like, anxious. And I think, having a really healthy diet can help with some of the symptoms and emotional side effects of the Depo-Lupron. So whether it's Whole30 or Mediterranean, really it's whatever diet that you can follow, I think would be really good to do. And then you don't have to wait to start all the egg quality supplements. Start them now. The CoQ10, the NAD, the NAC. Take an extra calcium supplement as well. That's what I tell my patients to do who are on Depo-Lupron. And I wish you all the best in late April or May. Okay, this last question is from Rupa. And Rupa says, I'm 32 years old and I've had 3 miscarriages before 10 weeks. And the second one was a blighted ovum with trisomy 4 and the third one tested normal by chromosomes. I got all my tests done in the last few weeks under your main Angel method, and my AMH is 1.19, FSH 7, estradiol 28, AFC 11, prolactin 7.8. My husband's sperm analysis and fragmentation came in all normal except for 2% morphology. Both of us are taking supplements recommended on your website since January 1st. My HSG showed that my left tube was blocked, some possible polyps and likely endometriosis. I'm scheduled to meet Dr. Nezhat for a laparoscopy, hysteroscopy. What do you recommend? IVF egg retrieval first or get the laparoscopy done first? Really looking forward to my consultation with you. Okay, Rupa, this is super fun. Thank you for sharing this with me. I would also recommend genetic screening, doing chromosome analysis on both you and your husband. However, we already know that you had one pregnancy that was positive for trisomy 4 and one that was supposedly tested normal, but we also know there was another one, but we just don't know what happened. So I would still do that just to rule out something that is really, really rare, but I think it would make us feel really silly if we missed that. The other thing is doing a thrombophilia workup. It sounds like you did the whole Angel method and went through that checklist. But if you haven't done the thrombophilia, that's also something else that I would do, as well as look at antiphospholipid antibody syndrome. I can tell you that when my patients wake up from surgery and they find out that there's no tube attached, because I bet Dr. Nezhat will remove that tube, remove all the endometriosis and the polyps, that psychologically it doesn't feel as good waking up to having no embryos than to have embryos waiting for you. So I suggest in my patients in general, I don't know your entire history, but in general, I recommend doing IVF first so that when you wake up from surgery, you have embryos waiting for you and you have something to look forward to. Because if you don't do IVF first and you do surgery, and let's say your IVF cycles don't go well, it actually causes even more depression and sadness than you already have. So my approach, as you guys know, diagnosis before treatment. It sounds like you have a really good idea as to what's going on. Surgery is going to be something that we are going to take advantage of. But whether you do surgery now or wait, it's really the emotional response that you'll have that will help you make the decision as to what to do next. Okay. Well, thank you guys for joining me on Ask the Egg Whisperer. I think I've answered over 1 billion questions over the last 6 months. Well, it feels like it, but only in the most wonderful way, because obviously you can tell that I love hearing from you guys. I love getting your questions, so keep asking. You can go to asktheeggwhisperer.com to enter your question. Thank you for joining me tonight. I'm going to go ahead and look at your live chatted questions here to see if I could help by answering any of them. Let's see here. I'm going to get there. Okay. Hi, Dr. Amy. You recommended whey protein to help prevent OHSS, but what do you recommend for those who are plant-based? Well, I can tell you that Tom Brady looks amazing, right? He's like 100 years old, but he looks like he's 20. He has a plant-based protein. Am I friends with him? Absolutely not. But my patients tell me that they love the taste of it. So he has a plant-based protein, you can get that. But plant-based is going to be just as good in my experience. So the studies that have been done looking at OHSS prevention and protein powders have been done looking at whey protein. But I'm sure that if we did another study looking at protein that's plant-based, it's probably going to be the same outcome. Let's see. Hi, Dr. Amy. You mentioned to avoid hard liquor, plastics, and THC, not TFC. So no gummy bears for you. Hello, do you recommend PGS testing frozen embryos? So it really depends on the quality of the embryo and the strength of the lab. So you have to ask the lab director what they recommend. If they think that the outcomes are good in their lab from thaw, biopsy, refreeze for genetic testing, then it's okay. However, if your doctor is saying, no, it really will decrease the implantation rate, I wouldn't go for it. Hi, Dr. Amy. Do you think I need to do an immunologic panel testing after an IVF that ended up in a chemical pregnancy? Can you mention reasons for a chemical pregnancy? Absolutely. Reasons for a chemical pregnancy could be that the embryo was actually abnormal. Even when you find out that it's normal on the PGT testing, there can be smaller abnormalities that can't be detected because an embryo has such a tiny, tiny amount of DNA, and you can only see so much. But there could be other abnormalities as well. Number 2, there could be an anatomic issue inside the uterus. And when I say uterus, I also mean fallopian tubes. Number 3, it could be a timing issue of when the embryo is transferred related to when implantation should really be happening inside your uterus. And that's something that the ERA test could tell you. It could be due to silent endometriosis. It could be due to an immune issue or some sort of immune dysfunction. And when I say immune dysfunction, I'm not talking about going down the natural killer pathway and all that kind of testing. I'm talking about literally genes that are present in embryos that make it so that an embryo and a uterus may not be genetically compatible from an immune standpoint. And I know you're like, what is she talking about? Well, there are genes that are in the embryos and genes that need to interact perfectly with the lining of the uterus in order for an implantation to occur. And it's so frustrating when those things don't happen, meaning you transfer a gorgeous embryo, you've done all the things that you need to do, and you still get a biochemical. Those are the kinds of things that I'm thinking about. May I ask what's your opinion about DHEA for older eggs boost for patients 40 to 43? So I really like NAD, CoQ10, fish oil. And the reason is that I just find that DHEA can cause some side effects. And there's a version, it's the micronized DHEA version. So if someone wants to take it, I won't say no. Next question. Do you know any good IVF doctors in Chicago? I do. So Dr. Allison Rogers, love her. Dr. Sigal Klipstein, she's fantastic. And I can't remember, there's one other doctor. I'm going to butcher her name, so I'm not going to say it because that will embarrass me. But there are a lot of doctors. Yes, Dr. Emily Jungheim is fantastic. Great doctors in New York City. Yes, CCRM New York, great doctors. Shady Grove, excellent. Dr. Jeffrey Wing, super. And if I'm forgetting anybody, please don't get mad at me. If you're a New York doctor, and I didn't mention you. Would you do anything with a 1.5 centimeter fibroid at the top of the uterus before a transfer? Yeah. So if it's like sitting on top of your uterus like a bow, like a ponytail, no big deal. If it's inside the mouth of the uterus, like, see, fibroid inside the mouth, that's what I was just impersonating, then boop, you want to take it out before you do a transfer, right? Because there's no room for, I can't even go there with a better analogy than that. Next question. My FSH increased by 1.6 and is now 11 in a span of 3 months. My doctor said nothing about it. Should I be approaching treatment any differently? I'm 32, DOR, waiting to get an IVF calendar. I wouldn't sweat it. I mean, your follicle count is the most important thing, and your age is awesome. So I would just say, look, IVF is definitely the way to go, it sounds like, especially if you want more babies and you want to preserve your fertility. So it's always nice to have embryos on ice, so keep going, and I wouldn't sweat it. Can you go over the significance of acupuncture during IVF? Absolutely. So I find that acupuncture can really help my patients with their symptoms and side effects from IVF, meaning the bloating, the mood changes, the anxiety, the insomnia, the pains, the aches, the nausea. And then it also helps relax the uterus at the time of the transfer. So patients of mine are offered a session 30 minutes before and 30 minutes after. And then patients also do it after the egg retrieval to recover from the procedure as well. Next question is, let's see here. How do you feel about birth control for prepping for the cycle? So birth control is basically like IVF preparedness pills or IVF planning pills. I use them in patients who have a lot of eggs, who are high risk of OHSS. I don't use them in a lot of my patients because most of my patients have a follicle count that's less than 10. Okay, guys. I'm going to answer this one last question and I'm going to call it a night because my night's not over. I got to call all my lovely patients tonight to review their trigger shot instructions, and I'm so excited to do that. I've had 2 genetically normal embryos, both implanted, 2 confirmed pregnancies. First pregnancy, the baby stopped growing at 7.5 weeks. Second heartbeat stopped at 10. Lupus anticoagulant panel normal. Doctor doesn't have any other answers. So I'm really sorry that's happened to you. Unfortunately, that's an experience that I've had with my patients as well, and I'll share with you what I've done. I considered doing a hysteroscopy, sometimes even a laparoscopy as well. I've considered doing extra testing. So even if I had done the ERA and Receptiva DX test in the past, sometimes I'll even repeat it. The ERA test in a case like this wouldn't be as important, but the Receptiva DX might guide us. Rule out a uterine septum with a hysteroscopy. Ask your doctor about whether you have adenomyosis or not. Look at sperm DNA fragmentation and see if potentially that's causing the embryos not to be as successful at continuing to grow at a certain point. And then you really have to wonder if there might be some sort of incompatibility between your genes, your husband's genes, and the uterus. And that's where we start talking about the HLA-KAR genotype. And it's not that no embryos will ever implant. It's that things might just be a little bit less efficient in a case like this, and ask your doctor perhaps if that's testing that they would consider doing, especially if they've already done all the things that I mentioned. And sometimes we even just have patients take Lovenox, which is a blood thinner, empirically, because perhaps there is some sort of autoimmune issue that Lovenox, believe it or not, can fix. Or what if there is some sort of thrombophilia, or that we just don't have a test for, and I do this, there's no piece of paper I can show you, but perhaps taking Lovenox might help with this type of implantation success issue that you're having. So I'm sorry that you're going through all of that. Well, thank you guys again. I hope you fly. And when I say fly, you guys know what that means. First, love yourself. Remember to inhale courage and exhale fear. I said exhale free. Exhale freely and exhale fear. So remember to remember your mantra, squeeze your buns at all your blood draws. That's what I tell my patients when they're looking freaked out. I'm like, squeeze your buns. And as my sister says, as long as your buns have each other, you're never alone. Literally, she texts me stuff like that. It's really funny. I should read the threads, the text threads, because it's stuff that would just make you cry laughing so hard, and it's quite obscene, so I can't necessarily share it with you guys. Maybe one day. Okay, I love you all. Have a great evening. Thank you so much. Thanks for all the love, the hearts, and the thumbs up. You guys have a great night. Talk to you guys soon. I'll be back.